joining us today. This webinar will be recorded for future viewing and will be posted to acc.org under the Webinars on Demand homepage. We will begin recording now. The American College of Cardiology's CV Imaging Section Leadership Council is pleased to present this online education program titled Multimodality Imaging of LAA Closure. We are very pleased to welcome all of you today. And now it is my pleasure to introduce to you James Lee, MD, FACC. Dr. Lee is an advanced imaging cardiologist at the Henry Ford Heart and Vascular Institute Center for Structural Heart Disease in Detroit, Michigan, where he also serves as the Associate Director of Echocardiography. After receiving his medical degree at Wayne State University in Detroit, Dr. Lee completed his residency in internal medicine at Emory University in Atlanta. He then did an advanced imaging fellowship in cardiovascular CT and MRI at the Piedmont Heart Institute in Atlanta and went on to train in general cardiology at the University of Washington in Seattle, where he also underwent advanced echocardiography training with a focus on interventional echocardiography. Dr. Lee has a particular expertise in the emerging field of interventional imaging with cardiovascular computed tomography and interventional echocardiography. In addition to authoring many book chapters and review articles on valvular heart disease, he is a co-author on the 2017 American College of Cardiology Expert Consensus Decision Pathway for the transcatheter aortic valve replacement in the management of adults with aortic stenosis. Dr. Lee additionally sits on the American College of Cardiology's Imaging Section Leadership Council, where he leads the multidisciplinary structural heart disease work group. And with that, I'll turn it over to you, Dr. Lee.
Thanks, Tina. I appreciate the introduction. I'd also like to introduce my co-moderator, Poonam Velgadpudi, who is a structural interventional cardiologist, assistant professor of medicine, and associate program director for cardiology, the Cardiology Fellowship at the University of Nebraska Medical Center. She's the chair of the early career section of the ACC and co-chair of the SCAI education community. She is a social media editor for Jack Interventions and associate editor for the European Heart Journal case reports. We have three fantastic talks for you today, including the background of LAO closure, echocardiography planning of LAO closure, and the interprocedural guidance and the role of complementary of CT. We have great presenters from Dr. O'Neill from Henry Ford, Dr. Fazla from Houston Methodist DeBakey, Dr. Scher from Sanger Heart and Vascular Institute, and two great cases from Dr. Narang at Northwestern and Dr. Chen from the University of Pennsylvania. Without further ado, I want to introduce Dr. Brian O'Neill, who is a graduate of Wayne State University in Detroit and completed his medical residency at the Washington University in St. Louis. He moved on to the University of Miami-Jackson for his cardiology and interventional cardiology fellowships, and then was faculty at Temple University prior to assuming his role as the director of interventional cardiology research in the Center for Structural Heart Disease at Henry Ford Hospital in Detroit. Dr. O'Neill has an interest in LAO closure over the past few years, and with his colleagues at Henry Ford is the co-PI for the CORAL-AF IDE, which will investigate the safety and efficacy of the Lambre device for left atrial appendage occlusion. Dr. O'Neill, I'll turn it over to you.
Thank you very much, James, for that wonderful introduction. And so let me just share my screen real quick. Okay, great. Again, thank you, James, so much for that kind introduction. I'm going to be talking about the left atrial appendage closure history and the future. And these are my disclosures. All right, so we all know that that atrial fibrillation is associated with thromboembolic phenomenon, and the focus of the main focus of the treatment for left atrial for atrial fibrillation is anticoagulation, and the reason for that is because of thrombus. Here you can see a transesophageal echocardiogram with a thrombus in the left atrial appendage, and this is where 90% of the clots that cause thromboembolic phenomenon occur, and one of the reasons why anticoagulation in these patients is so important. So important, in fact, that this is a class 1A recommendation for patients that have atrial fibrillation and a CHA2DS2 VAS score of greater than 2. We have several different options for these patients in whom we want to anticoagulate, which are some of the medications that are listed here. For decades, Coumadin was the main choice for anticoagulation. However, with the introduction of direct antithrombin inhibitors, we now offer these patients some ability to anticoagulate without having to do the troublesome INR monitoring that is so challenging for many patients. However, despite the fact that we have some of these new regimens, we still aren't doing a really great job of anticoagulating these patients. This is some data from the NCDR registry, and you can see here as presented a range of CHADS-2 VASC scores amongst patients. And what we see is that along the entirety of the range of these CHADS-2 VASC scores, that we only really have a peak usage of oral anticoagulants about 50%. So that really represents a big challenge in terms of how we're managing these patients. With the introduction of some of these newer agents, we've had some improvement in the amount of anticoagulation that patients are receiving. If you look here on this chart, around the year of 2010, and the third quarter is when dabigatran was initially introduced, and this was the first of the direct oral anticoagulants out there for patients. And right around then, you also see in 2011 rivaroxaban, and finally apixaban, which was released in 2012. And you can see that there is some improvement in how many patients are being anticoagulated, but still, the vast majority of these patients, up to 40% who are eligible, are still not receiving oral anticoagulation therapy. And we know that this is a big problem because of the risk of stroke. This is again some data from NCDR, and it looked at 1.3 million patients with AFib, of which 43,000 had some sort of contraindication to a long-term anticoagulant. On the panel on the left, you can see that the rate of stroke actually correlates very nicely with the patient's CHADS-2 VASC score. However, if you look at the figure on the right, we can see that in patients, particularly that have had an intracerebral hemorrhage or some sort of intracerebral event that were on anticoagulation, that the rates of recurrent events are actually quite high. And this is, again, ranges throughout the amount of different CHADS-2 VASC scores in these patients. So certainly these patients that really need this therapy, really need stroke prevention, are the ones that are not being treated the most, and hence are at the higher risk of having additional events. And so that's really where the field of left atrial appendage occlusion came into being. And for the last several years, we've had that as an option. Now, this is a meta-analysis from the PROTECT and the PREVAIL trials, and really, the left atrial appendage occlusion is one of the most studied fields, I think, in all of interventional cardiology currently. We've had to really go on multiple different trials, going through multiple different FDA panels in order to bring this therapy to our patients. And so this is just a meta-analysis of these two trials. And we can see a couple of interesting things in this particular graph. So first of all, those patients that have had a history of a hemorrhagic stroke, these are the ones that particularly benefit from being evaluated and treated with left atrial appendage occlusion. We can also see that there may be a slightly lower risk of disabling or fatal stroke, and even a smaller risk of unexplained death if we go out for several years. Finally, as we all, being cardiologists taking care of these patients, are well aware of, there's less major bleeding with left atrial appendage occlusion. So that really is a lot of where the data is founded of why we're able to offer this therapy to patients. And the fact that in these same 2019 guidelines that I talked about before, left atrial appendage occlusion is now a 2B recommendation for those patients who may not be able to tolerate long-term anticoagulation. And as you'll see from data from the TVT registry, we're actually really getting very good at left atrial appendage occlusion. This is some of the largest experience to date from 2017. And what we can see is the comparison of the clinical trial experience versus the post-approval experience. Now, a couple of things to point out is in the clinical trials, obviously these were a very small amount of self-selected centers that were really very, very skilled at the various techniques which are needed for left atrial appendage occlusion, primarily the use of devices as well as transeptal puncture. In the post-approval experience, the vast majority of the experience is actually in centers that are considered to be lower implanting centers. So almost 50 to 60% of the experience we currently have is from those centers that would be termed new or inexperienced centers. And you can see a couple of things. So first of all, in the post-approval experience, the rate of major complications has really come down quite dramatically. You can see that in the table here, the rate of pericardial tamponade is only about 1.2%, and some of the other possible complications are less than 1% at this stage. So we're becoming much more experienced at left atrial appendage occlusion, and this is one of the reasons why that we're looking now at figuring out who we can possibly treat. This is some interesting information in terms of who is out there that could potentially benefit from this therapy. So, and this is from a Euro Intervention article last year. And we can see that in the United States, about 326 million people, if you look on the left-hand side of the graph there, have AFib. Or I'm sorry, 326 million people in the population, 1.5% of which would have AFib, which would then translate into about 3.6 million people that would need some sort of stroke prophylaxis. If you come down a little bit further and you see that of those patients who would fit the criteria for left atrial appendage occlusion, that adds up to almost 1.7 million people. However, through 2018, we've treated only about 40,000 people. That translates into about 2.3% of patients who would be otherwise eligible for left atrial appendage occlusion therapy are actually getting this therapy. The same is true in Europe. If you look throughout Europe, you see that only about 5% of those patients who would potentially be eligible are being treated. So we are making a lot of strides with the therapy. However, we have a long way to go in terms of being able to offer this to more patients. Some of our current challenges, and probably the biggest one that we're thinking about right now, is the concept of device-related thrombus. This is something that was initially noted from the TPT registry, and this is just a graph that shows that in those patients that have device-related thrombus, they do have a higher risk of ischemic stroke or systemic embolism and all-cause stroke. And this remains a challenge for us. How do you identify, how do you predict who's going to have it? And then more importantly, how do you treat device-related thrombus in a patient population who is at a high risk of bleeding from anticoagulation? We have many current, just really one device that's currently available clinically in the United States for left atrial appendage occlusion. That's the Watchman device. Recently, the Watchman Flex device is being rolled out and really addresses many of the shortcomings from the initial technology. Most likely at the end of this year or early next year, we'll also have the Amulet device, which will become clinically available. And there's a whole host of other devices that are currently in the works. And one that I wanted to highlight is a Lombre device. Now, the Lombre device is actually composed of two different components here. It has an umbrella, which is on the right, and then a cover. And this device is a little different than the currently available technologies, as it acts more of a cover as opposed to a plug, which is what some of the technologies are right now. So here you can see a Lombre case here. This is a patient that had a very short depth in the left atrial appendage, which you can see on the left right there, and then you can see in the echocardiogram lots of pectinates in a very short distance. Here on the left-hand side of the screen, you can see that we've deployed the umbrella of the device, and I'll just put the echo there. And now what we're doing is we're slowly unsheathing the device so the cover can come out and cover the appendage ostium. And you'll see on the fluoro it's slowly coming out, and then all of a sudden it's released. And on the right-hand side of the echo, you can see the same thing. Go to the next slide here. So now we're just doing our similar dye injection here on the left. With a little bit of a tug test, and on the right you can see that the device has completely occluded the ostium of the appendage right there. And this is a CT scan at 45 days, and you can see here the umbrella anchors are very well opposed in the appendage. The appendage is completely covered, and this also illustrates one of the challenges we're having now is what to do with these multi-lobe devices. And this device I think has a lot of potential in being able to treat those patients in very selected anatomy. So in summary, utilization of left atrial appendage occlusion therapy will continue to increase. We're currently going to be getting randomized trials versus DOAC very shortly, so we'll have even more data to support the effectiveness of this therapy across multiple different groups of patients. We continue to get experience with less invasive therapies. There's many centers now that are performing the procedure under ice, which will allow us to peel away the general anesthesia component, which I think can be challenging for some patients. And finally, there's more devices that are being evaluated on horizon and will allow us to treat even more patients. So With that, I want to thank everyone again, and I'll go ahead and mute myself and stop sharing here. Thank you.
That's a great presentation, Brian. Thank you so much. Let me ask you a couple of questions. Number one is, so the penetration of, or the use of Watchman is only 2.3%, 2.4%. What do you think we can do as programs in order to increase the number of patients who get this device or who benefit from this procedure? And the second question is, when the outcomes with Watchman device are so good, you said we are looking at other devices that are being tested. Do we really need more devices, or should we just try to get more patients to this device?
Those are both excellent questions. Let me start with your first one with regarding to how can we bring this therapy to more patients. I think we as implanters and implanters in the whole imaging team, we have to be, I think, a little bit more proactive in terms of communication with our colleagues and letting people know about the therapy. One thing that we have that's worked really well for us at Henry Ford is we actually have an Epic alert that will alert teams that a patient's admitted that has atrial fibrillation that's not an anticoagulation. And so efforts like that, I think, are a good way to really notify, be notified of these patients and reaching out to the patients, particularly those patients that are in the hospital, to let the teams know that, hey, we don't have to just try a fourth anticoagulant, or we don't have to just offer the patient nothing. There is this other therapy out there that's a way to stroke prevention. So I think if we look at this holistically, and we really are in the process, we really are as part of a stroke reduction strategy, whether it be with the device related versus anticoagulation versus whatever. We want to look at, I think, holistically, is not just how can we do more Watchman, but how can we really we prevent stroke, because that really is I think, an important part of our mission. To your second question, we I'm sure we'll get to the point where we're a little device saturated in terms of different therapies for left atrial appendage occlusion. As we all know, though, that left atrial appendages come in many different shapes and sizes, and so there's still certainly, I think, is a lot of room for device innovation to be able to offer this to more of these patients in these really challenging anatomies. Or some of those, we'll have to see kind of what happens in terms of further data with regarding to do we need that 45 days of anticoagulation? Can we get away from that? Can we just use DAP? So those are, I think, some of the important questions that we have to ask ourselves when we kind of get to that threshold: is how many devices is enough?
That's a great point. And then I just wanted to touch on the Watchman AF trial that's enrolling, where we're going to compare or look at Watchman versus oral anticoagulation. So maybe that would increase. We'll see what the results show. The results are not going to be out until maybe later after 2025 or 2027, but that would give us another indication to use left atrial appendage closure devices. So great talk. Thank you so much. And I will hand it over to Dr. Lee to introduce our next speaker.
Thanks, Brian. What a wonderful talk. And thank you, Poonam. Next up, I want to invite Dr. Faza, who is a structural disease imager at Houston Methodist DeBakey Heart and Vascular Center, to give a talk on interventional TEE and echocardiography for LAO. She did her residency at the Cleveland Clinic, fellowship at the Baylor College of Medicine, and a structural heart imaging fellowship at the Houston Methodist. She's an assistant professor at the Weill Cornell Medical College and assistant director for cardiovascular disease fellowship at Houston Methodist. Dr. Faza serves on the editorial board for JACC Case Reports and the Methodist DeBakey Cardiovascular Journals. Dr. Faza, take it away.
Thank you so much for this kind introduction. Okay. Good evening, everyone, and thank you for joining us today. I'll be going over the step-by-step survival guide to TEE imaging of a left atrial appendage occlusion procedure. I have no disclosures. The objectives are to review the TEE guided procedural for transcatheter left atrial appendage occlusion and highlight common complications of the procedure to emphasize the role of follow-up imaging by transesophageal echocardiography. As you know, the left atrial appendage can have different morphologies, and these include windstalk, chicken wing, cactus, and cauliflower. And imaging is really important in unmasking these different morphologies. The chicken wing morphology is common, but it's also challenging because it's shallow and broad. Each anatomical morphology of left appendage has a specific procedural specific. So these are the common left atrial occlusion devices, and they can be divided into those that can be deployed by the endocardial approach, which happens through a transductal approach, and these include the Watchman device and the amulet device. As mentioned previously, the Watchman device is FDA approved for use, clinical use in the US, and the amulet device is being studied under a clinical trial. The lariat device is deployed using endocardial and epicardial wires with a magnetic link, followed by epicardial suture ligation of the appendage. Baseline imaging at the beginning of each procedure is very important. As mentioned, the left atrial appendage is the most common site of thrombus formation and accounts for 91% of thrombi in non-valvular AFib versus 57% of thrombi in rheumatic atrial fibrillation. So baseline imaging is important to detect these thrombi, which constitute a contraindication to the procedure. To diagnose the clots, it's important to evaluate the appendage at multiple views and ensure visualization of the tip, because as you see in this example, the clot is very distal at the left atrial appendage tip. So while you're imaging, you have to use mid-esophageal and high esophageal views to be able to visualize the tip of the appendage. Contrast can be very helpful in differentiating a clot from artifact caused by Coumadin-rich shadowing and from the normal pectinate muscles that are present in the appendage. Baseline imaging is also important to evaluate for the presence of atrial septal aneurysms, interatrial shunts, mobile atherosclerotic plaques in the aorta, baseline pericardial effusion, because that helps you compare it to the final effusion if it develops during the course of the procedure, and for any intracardiac clots, which are also contraindications to the procedure. The left atrial appendage is imaged at the mid-esophageal to high esophageal views to allow the maximal visualization of the landing zone for the device to be used. Rotation and manipulation of the probe should be performed at every angle to ensure visualization of all the different lobes of the appendage. Accurate sizing is crucial, as undersizing the device can lead to device embolization versus oversizing the device, which can lead to left atrial appendage rupture. For the Watchman device, the size measurements are performed at 0 degrees, 45 degrees, 90 degrees, and 135 degrees. The landing zone is defined as the distance between the left circumflex artery to a point 2 centimeters below the tip of the upper pulmonary vein limbus, which is the yellow line in these images. The depth is defined as the distance between the landing zone and the most distal tip of the appendage. 3D imaging can also be useful to size the left atrial appendage. So this is an en-face view of the left atrial appendage ostium obtained by multiplanar reconstruction. And here you can appreciate that you're able to measure the maximal diameter and the minimal diameter of the landing zone. Exclusion criteria for the Watchman device include an orifice diameter that's either too small or too large. Exclusions also include left atrial appendages that are too shallow, where the depth is less than the largest orifice diameter, and when the depth of a secondary lobe, if present, is too close to the left atrial appendage, which can lead to an uncovered portion of the left atrial appendage. The Watchman device sizes that are available are based on the maximal. The devices available are 21, 24, 27, 30, and 33, and these are based on the maximal left atrial appendage orifice size that is measured by transesophageal imaging. After the device is deployed, we measure the compression diameter, which is measured at the shoulder of the device when the threaded insert is clearly visualized. So this represents the compressed diameter of the device. For the amulet device, the sizing is a bit different. The landing zone is measured 10 to 12 millimeters below the ostium, while the depth is measured from the ostium to the left atrial appendage wall in a plane perpendicular to the ostium. Procedural steps include transseptal puncture, advancement of the delivery catheter, contrast angiography through a pigtail catheter, device deployment, device release, and finally screening for immediate complications. It's important to understand the TE equivalence of fluoroscopy views because as interventional imagers, we have access to fluoroscopic views and to hemodynamic monitoring, and this helps us monitor and evaluate the procedure. So the right anterior oblique caudal view corresponds to a 130 degrees on the TE, and that shows you the major axis of the left atrial appendage orifice. So you can obtain that by getting your 135-degree view and then rotating it counterclockwise. The right anterior oblique cranial view corresponds to 45 degrees on TE and shows the minor axis of the left atrial appendage orifice. The first step after getting venous access is transseptal puncture, and the ideal transseptal site for left atrial appendage occlusion is inferior and posterior. So this is a biplane view. This is a short axis view showing the aortic valve, and this marks the anterior aspect of the fossa. And this is the posterior aspect. You want to be posterior. This is a bicaval view showing the SVC, which marks the superior aspect, and the IVC, which marks the inferior aspect. And in this view, you want to be more inferior. 3D imaging can also be very helpful. This is demonstrating the tenting of the septum by the transseptal needle. And the following image demonstrates the advancements of the guide catheter. 3D imaging is helpful because you can appreciate the whole length of the catheter as it transverses the left atrium into the left atrial appendage. And if you look at the trajectory here from an inferior posterior puncture, it's heading straight towards the appendage. If you go for a more anterior puncture, then the trajectory is less ideal. 3D imaging allows continued monitoring of the distance between the septum and the tip of the guide catheter, and that prevents accidental decannulation. After that, contrast angiography is performed to determine the anatomy and the morphology of the left atrial appendage. After that, the pigtail and the guide catheter are moved where the radio-opaque markers are at the ostium. This is followed by device deployment, as visualized by fluoroscopy and TEE, and finally a contrast injection to confirm adequate closure of the appendage. And these are 3D images showing the catheter in the left atrial appendage, followed by device deployment, the contrast angiography where the bubbles kind of obscure the imaging, and finally device release. Before the release of the device, the 4 pass criteria must be met. The P stands for position, where it's important to ensure that the device is properly positioned with no tilting. So it has to be deployed in a fashion that's parallel to the landing zone. The second step is checking a tuck test to make sure that the device is well anchored. Next is checking the compression diameter to make sure that you have enough compression of the device. And lastly, checking for a peri-device leak. These are examples of optimal versus suboptimal device positioning. So the optimal deployment is when the device is parallel to the plane of the landing zone without excessive shoulder of the device. When the shoulder is protruding and the shoulder is this curved portion, then this indicates that the device was deployed in a tilted fashion. So this excessive tilting and excessive protrusion of the device should be avoided. And this is an example of that. Peri-device leak is important to evaluate for, and this is again performed in multiple views at different angles. And it's important to use the low requisite limit to detect low velocity flows. The largest leak is usually documented, and it's relevant when it's more than 5 millimeters for the Watchman device. If a significant peri-device leak is detected, then the device needs to be either repositioned or replaced with another size. 3D imaging can also be very helpful in evaluating the circumferential extent of a peri-device leak. So this is an example of 3D imaging of the device, and the color here shows the extent of the leak. The amulet device deployment is a little bit different. This is a partially deployed lobe known as the ball. It's advanced into the left atrial appendage. This is followed by full deployment of the amulet lobe, After that, the disc is deployed, and important to make sure that this is concave in shape and that there's enough distance between the lobe and the disc. And finally, the device is released. For the amulet device, a PDL less than 3 millimeters is accepted. Procedural complications include pericardial effusions, which can result from injury from wires or catheters. Special attention should be paid to the RV-RA junction, and it's important to use transgastric imaging to screen for these pericardial effusions. At any point in the procedure if there's any hemodynamic instability, it's important to pause and screen for pericardial effusions. Vascular injury is another rare complication, as the appendage lost in close proximity to the left circumflex artery and the greater cardiac vein. So monitoring for wall motion abnormalities can be helpful. The device, if it's oversized, can interfere with mitral valve function. So evaluating mitral valve function is important at baseline at the end of the procedure to make sure that there's no interference with the leaflet motion. Device embolization, again, is a very rare complication and results from undersizing of the device or suboptimal positioning. And this is an example of a device that's embolized into the left atrium. These usually can be snared. Iatrogenic ASDs are expected after transeptal puncture. So at the end of the procedure, after all the wires and catheters have been removed, it's important to assess the size and directionality of the iatrogenic ASDs. These are usually percutaneous closed if they're too large, more than 1 centimeter, or if they're resulting in bidirectional shunting in the setting of pulmonary hypertension or severe TR. This is why it's important to have a comprehensive baseline evaluation at the beginning of the procedure. 3D imaging can also help sizing the ASD in case percutaneous closure is indicated. Follow-up imaging is performed 45 days after the initial implant, because that's the time it takes for the device to fully endothelialize. At that time, we assess device stability, presence of peri-device leak, and presence of device-associated thrombi. It's important to note that a thrombus on the excluded side of the appendage is normal, and device-associated thrombus is usually usually at the site of the threaded insert. If the device is stable with no evidence of leak or thrombus, then we can stop the anticoagulation and start dual antiplatelets for 6 months, followed by aspirin monotherapy. So in summary, TE plays an instrumental role in procedural planning, in addition to procedural guidance, detection of complications, and procedural follow-up. Thank you so much for your attention.
Thank you so much for that talk, Nadine. That was very, very helpful. So let me start off with 2 questions, and then Dr. Lee will take over. So number 1, do you do 3D measurements? And if you do, can you tell us a little bit about that? And are you making 3D models before your procedures or not? And my second question is preoperative sizing. Are you using a CT or are you using TEEs to do the preoperative measurements? Because there is a difference between the two, right? And then if you want to comment on that.
That's a great question. I think we're very fortunate to be practicing at a time where multimodality imaging is so advanced. So you have the option of doing a CT, you have the option of doing a TE or ICE in some cases. And for challenging cases, you can always use CT images or TE images to make patient-specific 3D models and actually try the different sizes and see which device would fit the best. It varies by case-to-case basis. Some patients get the sizing by TE and others by CT. ICE has been also, we've been using ICE more and more in patients who are not getting full anesthesia. Our practice is mainly TE based, but for challenging cases, definitely look at a multimodality approach on fuzz view with the 3D imaging to evaluate the elliptical shape of the appendage. And then again, for the complex cases, 3D printing.
Great. Go ahead, Dr. Lee.
Yeah, so great talk, Dr. Faza. Just wanted to ask you a couple questions One is, do you find ever that the septal crossing points other than posterior and inferior to be helpful? And what tips do you have for the audience in using 3D for the transseptal crossing? I saw you had some very beautiful pictures of that in your presentation.
Thank you. Great questions. I enjoy 3D imaging of the septum. So to start with, as I showed in my image, when you go inferior and posterior, you have that anterolateral trajectory straight into the left atrial appendage. So this is usually the ideal site, because if you use that puncture site, that's when the trajectory is going to be heading straight to the left atrial appendage. So there's less challenges with catheter and wire manipulation that way in the appendage. 3D imaging of the septum can be helpful. What I would recommend is when you set your 3D zoom box, make sure to include the septum, the part of the mitral valve, and the aortic valve. And the same applies when you're changing your elevation width. Once you hit 3D zoom, you can orient the septum in a way where your mitral valve is at 6 o'clock, your aortic valve is at 9 o'clock, and then you can have a clear visualization of the fossa. When you change the gains, you can actually, it looks like a clock face. So you can identify the superior and inferior aspect, as well as the anterior and posterior aspect. And with the interventional attending or the proceduralist tenting from the right atrium, you're able to see that tenting and confirm the posterior inferior location of the needle.
So there's a comment in the chat box about the sizing. That's correct. The Watchman Flex device is size 20, 24, 27, 31, and 35. And you need the depth. Also, you don't need as much depth as you needed for the old Watchman device. The other thing is you're able to do a little bit smaller appendages, up from 14 to up to 31, even with the new Flex device. So excellent comments. Now, Dr. Lee, did you have any other questions?
No, that was a great talk. Thank you so much, Dr. Faza. And we'll now move on to our next speaker, Dr. Marcus Scher, who's the Director of Cardiac CT and Structural Heart Imaging and a clinical cardiologist at the Sanger Heart and Vascular Institute within the Atrium Healthcare System in Charlotte, North Carolina. He received his undergraduate and medical degree from the University of Wisconsin-Madison, completed his residency at the University of North Carolina, Chapel Hill, and his cardiology fellowship at Rush University in Chicago. He has been a cardiologist since 2000 and added cardiac CT to his clinical practice in 2005. His career focus is on cardiac CT, echocardiography, and education. Dr. Scher is involved in quality improvement in instruction for coronary CT, structural cardiac CT, TEE, and on clinical research trials for transcatheter structural heart therapies. Dr. Scher, it's a pleasure to have you here.
Thanks, James. So in the next 12 minutes or so, I'm going to share with you my experience with CT imaging for LA appendage occluder closure, and how it can bring value to practice. I'll just disclose that in our practice, we are screening nearly 100% of our patients with cardiac CT. So what are some of the reasons we can, why we would do this? Some of the advantages from CT from a screening standpoint is non-invasive. We can get very precise measurements for device sizing, and it can provide us a roadmap for procedural planning, including the implant angle, the transseptal puncture, even delivery sheath, and identification of important anatomic challenges. And all this, we may also have a role, show a role of post-implant follow-up scanning, just like a TE. So there's, although it's still, CT is still the new kid on the block, and this is the early experiences in small single center experiences here. We know that, the CT, similar to the TAVR experience, it shows that the maximum widths and lengths are often larger than TE, even if you use 3D TE approach, and that in small series also demonstrated CT guided measures could predict successful implant and seal better than TE based on pre and post CT assessment. And it can also be very accurate with post implant surveillance, as was demonstrated in this. Now, why may some of this be? If you think about it, when you do TE, certainly when you do 2D and you interrogate an elliptical structure, there's a chance that your interrogation plane is not really hitting the minimum and maximum diameters. when you have a very high spatial resolution data set in a robust workstation and you acquired everything you need in advance, you can get very precise measurements. Now, I know some may say, well, let's just move on to 3D TE imaging so we can be more precise, but it still undersizes compared to CT. And some of that has to do a bit with spatial resolution. Although we have excellent axial resolution, we don't in the other planes, in the through plane and the lateral planes, we do not have that spatial resolution, whereas on CT, we're less than 0.5 millimeters in all planes. So this is our protocol. It's very incumbent on us, though, if we want to have good results, to have very high quality images. And so this is why sometimes it's not always done everywhere, because these can be difficult patients and they're very frequently arrhythmic, and it takes a little bit more to get a good scan. This is our protocol. We typically, it's BMI dependent how much contrast we use, but we inject anywhere from 5 to 8 milliliters per second. We have to do a diligent breath hold in order to avoid misregistration artifacts in our multi-bead acquisition. And we do delayed phase imaging after our initial CTA to distinguish stasis versus thrombus, which I'll show you examples of in a bit here. We also do high resolution, 0.5 to 0.75 millimeter thick recon, so we can get very precise measurements. And typically this is done at the end of the T-wave. So this is an example. Hopefully this play is not too choppy for you, but what you can see is the same patient, T on the left, CT on the right. You can see the anatomy very well, but you have to get a good image when the appendage is the largest. A lot of people think of CT as just a static image set, but you can get cine images like this, and we have to get a good image at the right time in the cycle. And a lot of these patients are in atrial fibrillation, and we can't just do standard reconstructions if they are, because if we did percentage-based recons, we can mix systoles and diastoles on different beats, and we get these funny artifacts by doing that. But if we think about it, systoles tend to be pretty fixed in milliseconds, so we can do millisecond recons, and you can see the same patient. It always ends up on end systole on the end of the T-wave in milliseconds. And this is just a nice example of the importance of good reconstruction methods, because you can see here on the left that you have, this ghosting while it's in percentages, while all we did was shift the recon method to milliseconds, and you can very clearly see this nice cine image of when it's reconstructed that way. So one of the things that's really important, and it's talked about, throughout these talks, we have to exclude left atrial appendage thrombus. And this is two different views. We can mimic the views on TE, right? This is like a 45-degree view, and this is like a 135-degree view, as was mentioned. And you can see these are very prominent trabeculations. When we get image quality like this, it's easy to distinguish trabeculations from thrombus. And this is a clear-cut case of no appendage thrombus, but trabeculations. This is a clear-cut case of appendage thrombus. You see this pedunculated, low attenuation density here. This is a thrombus. But we get this stuff in between, and a lot of criticism said that CT was overcalling thrombi, and what we learned over time was that's because of this phenomenon of stasis. Remember, contrast is denser than blood, and when the patient's laying on their back, which is here, the contrast has a hard time going to the anterior superior lobe of the appendage, and you'll frequently see this flat cutoff line like oil and vinegar. But when you scan the patient automatically and put in your protocol to scan them 30 seconds later, you give time for that to fill in, and we can say that that's indeed just stasis, not a true filling defect. Now remember, all of this can be very much a spectrum, and there are spectrums of severe stasis, sludge, and so forth. So this is an example of how you can overcome that even by CT sometimes. This is a patient supine scan, and even on the delayed images, you see a filling defect that persists. We even scanned them at 5 minutes, and still there was a little bit of a defect. So what did we do? We repeat the scan, and we take advantage that the appendage is pointing down now when we put them on their belly and scan them prone. And the contrast actually gets stuck in the appendage on the delayed. This is very severe stasis, but there is no filling defect, so there is no thrombus. And just another example of this. This was a patient that had multiple TEs and was going to get a cardioversion, and people were afraid to do it because they thought there was a thrombus. There's the contrast TE. Hard sometimes to distinguish sludge or thrombus. And what we did was, instead of doing a third or fourth TE, we bit the bullet. We did a CT scan, multi-phase. This is a mimicking X-plane view of the TE. It does look a little suspicious here at first, but when you look at this, this is stasis and trabeculations, and you can see it filled in down there. You can even see the trabeculae. There was no thrombus, and the patient got cardioverted. Now, we've talked about the different morphologies, and this can impact our choice of device, and it can also impact our likelihood of success. We have to consider the 3D anatomy externally and internally. And so this is a patient of ours that had very heavy trabeculations. We can take our journey through the trabeculae here and see this is very heavily trabeculated. You can imagine the feet may have some difficulty expanding here. And this is a case of this where you can see this appendage here, very heavy trabeculated on the 3D image, and you cannot just measure the length out to here because you can't use it. You can't get stuff past this very heavy trabeculation. In this case, we needed a length of 14.3 millimeters for a device 31 based on these crisp osteal measurements here where the blue line is. And we just didn't feel like this was a good one for the Watchman device. The ostia come in different shapes, round, elliptical, some others. The elliptical is our most common that we see. And this can affect, our choice of devices and sizing. So this is currently we use the Watchman Flex. It can affect the shape, the deployment, and as can the internal trabeculation. Some have talked about the amulet device as well, and we have not been involved in this trial, but this is much more forgiving in terms of how much depth you need. And we think we can be much more selective now, similar to TAVR. We may have once this becomes approved, we think certain patients' anatomy will be more favorable for this device. This is an example of how we do this. We happen to use a CPR technique, curved multiplanar reformat on CT. We get a good quality data set, find an end systolic image where the appendage is the largest. You can see this is like a TE view, short axis view, and this is like a bicable view. You can see where the transeptal puncture is, how this aligns with the trajectory. And this one would be basically an inferior and a mid. We put that in our report. We have the osteal dimensions. This is the cath lab angle where it's coaxial line. And we know this trajectory. This is what the catheter should look like. Now, in terms of choice here, I just want you to know sometimes this affects which curve we may want to use. And if you can imagine these circles here representing our transeptal sheath, the anterior curve likes to point this direction. So if you have an appendage pointing this way, you may want to use an anterior curve. The double curve, you have to do a little more work and put counterclockwise torque to point it up that way, but it's very commonly used, especially if it's not pointing directly north. And then this straight curve, if the appendage for some reason was pointing down, that would be an issue. So we like to individualize, and most of the time it is an inferior mid or inferior posterior stick, but we find some variable relationships. Now here's a patient just another case example, last one I'll show, where we have again, the CT images here. This is the red line is the osteal plane, showing the size there. This is a short axis view. This is a bicable view. And we can see we have a sizing chart here, as others have talked about. And we have, based on what we saw, we have this coaxial implant angle of REO 27, caudal 17. And we would pick a 31 millimeter device, and we have enough length for that based on this. And this is what it looks like. So you can see this green line mimicking what we think the trajectory will be in the cath lab, and it's a very nice match for where this landed. So just to finish up on post-implant, some of the things we can look at, similar to the concerns on the post-follow-up T or device endothelialization, peri-device tissue gaps, peri-device versus intra-device communication, where we see contrast in the appendage and device-associated thrombus. And this is the ideal case, right, where we have complete seal, complete endothelialization, nothing's leaking around it, there's no device-associated thrombus. This is what we want to see. However, here's an unfortunate result of a Watchman implant, where you can see the device is very poorly seated and there's device-associated thrombus. This is not having a seal here. This patient is not protected. And then there's this whole issue of hypoattenuated thickening, which is a new term and finding on the device that I would consider it akin to HALT. in TAVR valves, the hypoattenuated leaflet thickening. This is hypoattenuated thickening on the device. This is very common. If you look closely enough, you'll see in these recesses, this low attenuation material. It's low grade. In this case, this is an example of ours where it's only about 2 millimeters thick. We believe that if it's less than 3 millimeters thick in a small series, has demonstrated that this may be safe to still stop anticoagulation. Low grade HAT may resolve spontaneously, and it's not been shown to be associated with embolic events. Once you get to 3 millimeter or pedunculated or mobile, you'd be much more concerned. So to summarize, CT may help select ideal device sizing and type as we move on to new devices for success and screen in or screen out candidates that are suitable for LA appendage occluder. It can provide a very precise roadmap for implant planning that may improve procedural efficiency, and post-implant CT follow-up can be an alternative to TE to assess procedural success, but all of this warrants additional investigation. Thank you.
Thank you, Dr. Scherer. That was excellent. So this question is to you or to the panel or the speakers. So we've noticed that with the TE, the left atrium and appendage are very, what would I would say susceptible to like volume status. So when you bring patients for a pre-op, pre-procedure assessments, the TE measurements may be smaller, and CT actually gives much more reliable measurements. We see that the ostium may be 2 millimeters more than the TEE, and the depths are 3 to 4 millimeters greater as well. So just to an open question to everyone, are you seeing less device size use when you do pre-op CT? And can we get by with an ICE in these patients for the procedure if you're doing a pre-op CT?
Yeah, I think that's a great question. We typically are pretty spot on with using one device per. Sometimes we've had to switch to another device, but most commonly use one device per case. The issue that you mentioned about the hydration is relevant, but quite frankly, we find that even when the LA pressure is raised, that we still get bigger size on CT for some of the reasons that I mentioned. I think that it's a very key concept that you said that if we want to totally move away and maybe use conscious sedation and do ICE in the future, that if we can have a very robust screening tool that tells us, for example, in the future, should we use an amulet device or should we use a Watchman? But then we know, and we have that much precision with the CT that you can just guide it that way and have confidence in that. So I think those are all excellent points, and I think the needle is moving on all of this.
So there is a question from the audience about relying on CTA for screening, and they've completely eliminated screening with the Flex device. And also a following question is, could you please comment on the peri device versus the intra-device leak by CT post-implant?
Yeah, so the post-device implant by CT, what you do is, again, you want to get a very high quality data set, and similar to how you look for perivalvular leaks on CT, you would circumferentially interrogate around the device and look for a gap, a tissue apposition gap, and you would look for as well a contrast getting into the appendage. If there's truly a seal and the device is endothelialized, you should see no contrast penetrating the appendage. The issue is you can get a mixture sometimes where you scan them before they endothelialize, so they can get contrast going through the device and around it. Now, I will agree that what we don't have a clear-cut concept on is how much of a peri-device leak equates to the 5 millimeter rule that we developed from transesophageal for Watchman, that it's safe to stop anticoagulation, because sometimes the anatomic translation to a color Doppler jet is not 1-to-1. But we certainly can see how big these gaps are and how much of the circumferential involvement of the device is at hand. I think you had another question. I didn't answer the first part though. What was that, Poonam?
So one of the audience members said they completely eliminated a pre-procedure evaluation after the Watchman Flex. Do you have any comments on that?
Yeah, I think that we still see, and I will grant you it's a minority of cases, we still see some patients that are screen failures, and I think it's nice to know that in advance. If you have easy throughput to your CT scanner, and it's you think it's safe for the patient, it's a little more information sometimes goes a long way. I think we can be very precise about the sizing, try to get the optimal result for the patients, and not have any surprises. I think the more we do structural heart, the less we like surprises. We've had some difficult flex implants because of deep, very prominent trabeculations close. We've had some, close to the ostium. We've had some ostial pit lobes. I think it's very nice to see some of that in advance for some patients.
Hi, Marcus. We have a couple of technical questions here. One is from the audience about whether it's worthwhile to just scan prospectively at end systole rather than doing a full retrospective scan, and a question about what the setup of your lab is in terms of do you have a dedicated 3D lab and how the processing works?
Yeah, so I think in these patients, the majority are elderly, and we scan them with retrospective gating with a low pitch spiral acquisition that's heart rate dependent, how fast the table moves. And we do pulse them in milliseconds on the end of the T wave when the image quality needs to be the best. That's when the appendage is the largest at end systole. So a lot of times we'll pulse them maximum 240 to 250 milliseconds to 400 milliseconds. Now that being said, I don't think there's a huge role in trying to do prospective and spare some radiation in an elderly patient that you're just trying to make the correct diagnosis. I think the trade-off is not worthwhile. Remember, when you do things with full cardiac cycle acquisition rather than a step and shoot prospective acquisition, you have more flexibility. And if there's any problems with ECG, counting, with the heart rate, or you need to do some ECG editing, you have that flexibility. So I just don't think it's worth the trade-off for doing that. And what was the other technical question, James?
Sort of what the workflow of your lab is, and how you have things set up.
Yeah, so we do have a 3D lab, and what we did was I spent some time training them. Obviously, I didn't have enough time to go into all the details of how we created that 3D shell, the CPR images, how that translates to transseptal, but we've trained them how to create that image set. And sometimes they don't get the trajectory right or the ostial plane right, but it's very nice. They package it for us. They know which phase to pick. And I just, Ira, one of my other partners, edits it a little bit, and that saves us a lot of time because we do a lot of these scans. And they can process it usually within about, I would say, 5 to 10 minutes. And then that saved us that time, and we can work on it if we need to tweak it or edit it, similar to our TAVR measurements that we've trained them to do. And they're very good at it.
Well, we have a lot of questions. I will close with this one last question on how you could use CT. Could you comment a little bit more on how you would use CT with optimal transseptal puncture location?
Yeah, so let me just see if I can show this here. When we do, the way we do it, this is a technique we decided to do in our own institution, is this CPR method of going from the transseptal to the desired location of the appendage. And when you do that, you can create these views that mimic like a TE short axis view, which is anterior and posterior. And here's the IVC over here, and the SVC would be here. So this is like a biplane view showing you, and this is just to give you an idea of how much you're expecting the catheter to do in 3-dimensional space when you're doing fluoroscopy. So we're showing on this areocaudal view, which is coaxial to the ostial plane, which is right here. the transeptal puncture, this good location for a straight shot to where we want to go is right here. This is where it is. And this is not a view you can get in the cath lab, REO 66 cranial. The only reason I show this is, imagine, if you will, turning this down and looking at it from the top down. You can see we're not really asking that much of a curve or bend on the catheter. And granted, the appendage, when you put the device in, it straightens out a little bit, but this is pretty easy to get this trajectory from here to where you want to be. Now, you can say, well, it's always inferior and posterior, but that's not true. You will see some variant anatomy sometimes where maybe the appendage is pointing down and you could come up higher on your transeptal to come over this way, or you have something that's very vertical and you really want to get extremely inferior when it's pointing up that way. So I think all this three-dimensional space data, if you can reconstruct this and rotate the images and see all these views and translate the 2D view to a 3D view, you get a very good sense of this transeptal puncture location.
Dr. Scher, what a tour de force of CT for LAO closure, and it really speaks to some of the importance of using CT imagers to really understand the cath angles, what happens in the cath lab. So thank you so much. What a great talk. I want to go and move on to our cases now. Our first case will be presented by Dr. Narang, a cardiologist at Northwestern Medicine and assistant professor of medicine at Northwestern University's Feinberg School of Medicine. Dr. Narang practices advanced cardiac imaging, including structural echocardiography, cardiac MRI, and cardiac CT. He's particularly interested in treating patients with structural heart disease, and Dr. Narang's research interests include artificial intelligence and applying cardiac imaging and novel tools to better understand patients with valvular heart disease. Go ahead, Akil.
All right. Thank you very much, Dr. Velgapudi and Dr. Lee, for organizing this webinar. I will present a case today of a challenging left atrial appendage occlusion, and it's called windsock cactus chicken wing oh my. No relevant disclosures, so I'll get right into it. So this is a 74-year-old male with a history of long-standing persistent atrial fibrillation, hypertension, diabetes. Recently had a major bleeding event while on warfarin, so was switched to apixaban. And unfortunately, while on apixaban, had a TIA. TAS2 VASC score was elevated to 5, and so he was then referred for a watchman from another institution. And we'll go ahead and start with the procedural screening TEE. And as many of you might be doing in your particular labs, often the first step in these situations is to do a screening TEE. I think this case particularly reflects the real world setting where sometimes the imaging is great, sometimes it's not, and sometimes we have to use multimodality imaging to really optimize the screening to be able to size a particular device. So from this screening TEE at this angle with biplane, you can get the sense that what we were anticipating is a windsock type of morphology of the left atrial appendage. However, when looking a little more closely, this is a short axis view in which, again, we're biplaning. This actually gives more of the appearance of a cactus. And so the morphology is already becoming a little confusing. And I think it does depend on what the morphology is to correctly select a device and also size it. From the screening TEE, we saw that the left atrial appendage ostium varied in length from 13 to 19 millimeters. So quite a large range here. And I think we did need some more precision to be able to further characterize this and optimize it. We had an excellent lecture from Dr. Scher right now. In our lab, we do use a combination of TEE and also cardiac CT to size these. And let me play this video, and I'll give you, I'll let it play once or twice so that you can take a look at the left atrial appendage. Hopefully it's playing on your end, but one thing that we noticed, first of all, is that the appendage morphology is actually more that of a chicken wing. And I'll talk about why that's important in just a moment. But we do see here, with a reasonable quality image that the appendage has a certain morphology, and from here we're also able to size it because of the excellent spatial resolution. And here we got an ostial dimension of 19 millimeters with a depth of 25 millimeters. And again, from this, I think the chicken wing morphology really became apparent. Why is this important? I think in practical purposes, for those of you who perform implants and also those of you who perform screening for this procedure, the various sizes that have typically been associated with the left atrial appendage actually do have differential outcomes with respect to occluder devices and also for potential for forming thrombus in areas that are uncovered by the occluder devices. And this is a nice paper from Dr. Leg's group that really uses some of the advanced TEE imaging and transillumination to really demonstrate some of the morphologies of the left atrial appendage. I think when we have optimal imaging, it's a great thing to be able to look at, but often in situations such as my case, we don't have optimal imaging. So based on our CT analysis using 19 millimeters as the max ostial dimension of the appendage, a 24mm device, Watchman Flex device was selected. We talked briefly about this, but the Watchman Flex is the newest generation of the left atrial appendage closures. It's been available actually in Europe for quite some time now, and it's only making its way to the United States over the past 6 months to a year or so. It is available in 5 sizes, ranging from 15 to 32mm in width. And so we can actually treat smaller ostia and also larger ostia. It's a self-expanding nitinol frame structure with fixation anchors. One of the benefits is that the face, the proximal face, is quite flat and has a minimal area facing the left atrium. So that actually encourages endothelialization and reduces post-implant thrombus formation. Importantly as well, the Watchman Flex can be partially recaptured into the axial sheath, remaneuvered, and repositioned more proximally or advanced distally several times before actually releasing it. And you will note here from our sizing guide that there's actually overlap between the various sizes that are available in our particular situation, between 24 and 27mm. This is the procedural imaging. So we did select a 24mm device to go in for. And this is the procedural imaging again for fluoroscopy that again demonstrates the chicken wing shape of the left atrial appendage. And here we're able to remeasure things and get an ostial dimension of 20mm. We saw a few of these slides in some of the earlier presentations, but the way that the device is, I'll go back, sorry, the way that the device is actually deployed can use one of 2 methods. You can use the advanced method, which is using the distal marker band, or the unsheathed method, which is implanting shoulder method. And actually, you can use a combination of both methods. I won't go into the details of them here, but those of you who are aware, we often use a combination of methods to be able to deploy the device. So this is the procedural imaging from this particular case. Now, I think this was a particularly difficult case for our situation. So despite many attempts at a distal deployment, both anteriorly and posteriorly, as you can see here, we could not get the satisfactory positioning of the device, which would either show, unfortunately, a gap on the mitral side, or it would be deployed in a canted position, exposing the ostium and the body of left atrial appendage to flow. And so I think there was a lot of challenges with actually just positioning the 24mm device, and it did not demonstrate adequate stability when we tried doing deployment method distally. And so unfortunately, we felt that this was not an acceptable option for us to continue with this sizing of the device. And so these are still images that show the highlights of the procedural imaging that actually failed with the 24mm device. Again, too proximal, there was a gap on the mitral side, and then it was positioned too oblique in multiple attempts. And so I think we can talk a little bit more about this in the discussion, but there are a lot of ways that we can troubleshoot these devices when we have challenges like this. I think we can think about redeploying the device either deeper or shallower. We can try biasing anterior or posterior, trying a different deployment technique that we talk about, either the advancement technique or the unsheathing technique, trying a different device size, a different delivery sheath curve, seeing if we can benefit from alternative imaging such as ICE. If there are challenges with the transeptal puncture site, that's something that needs to be taken into consideration. And occasionally, if the operator or imager are not experienced, sometimes just another set of hands can help with this as well. In certain situations, maybe this is not the correct device for the patient and we need to select a different device. Or in certain situations, we need to bail out completely and try a surgical clip. So in this particular instance, I'll go quickly just in the interest of time, we upsized to a 27mm device. So after multiple deployments, this was successfully deployed. It covered more of the limbus and the mitral aspect of the left atrial appendage, as you can see here, and had proportionally less of a mitral shoulder, so because of the larger device, and eventually passed the tug test. And so this was done ultimately under direct visualization with TEE and fluoroscopy and ICE, and we're able to confirm this positioning a little bit better, and eventually was deployed without complication and satisfactory positioning of the device. There's no peri-device leak with color Doppler and about 20 to 23% compression. And again, this was the failed deployment of the 24mm compared to the successful deployment of the 27mm device. Again, the fluoroscopic image here that shows the tug test injection, a little bit of contrast to see the well-fitted 27mm device and overall acceptable deployment and fluoroscopic imaging. A few months later, this patient was sent for for surveillance TEE that again shows the device seated nicely. It looks to be that there's no color leakage from around the device either. The on-FOS view, both using 3D TEE and transillumination, show that the device is nicely seated on the top of the left atrial appendage with good results. I won't talk too much about this. I think we've had a good conversation on the benefits of different multimodality imaging techniques, including TEE, CT, and then also CMR. We have a large CMR lab here, in which we do a lot of 4D flow and 3D reconstruction. And so we can obtain a lot of similar measurements with CMR as can be done with TEE and CT. I will skip this just in the interest of time. And what I do want to mention just a little bit, and Dr. Scherer alluded to this, I think there are a number of challenges that we have with transesophageal echocardiogram with sizing for devices. And I think a lot of it comes from the fact that when a lot of the procedures were developed, we weren't routinely using 3D echocardiography, and we were asked to be able to measure the ostium of the left atrial appendage at different angles, typically at 4 or 5 angles, and then come up with a dimension that reflected the largest ostium, pick a size of the device based on that, and go from there. What we started to see in patients labs who are potentially doing more transesophageal imaging, this can be done in real time, or it can be done offline, as we can actually use virtual reality. So we can take these three-dimensional data sets from the left atrial appendage, we can convert them into very easy to use virtual reality data sets in which we can manipulate the left atrial appendage, as you can see in the video on the left-hand side here, to really demonstrate what the true ostium of the left atrial appendage looks like on 3 dimensions, and from there actually size it. And so this is an example of how this actually works. We take a virtual reality left atrial appendage data set, and we look at it on FOSS to look at the ostium. And then from there, we can determine what the actual size is. And this is an example of a patient in which the conventional 2D data set measured 22 millimeters at greatest ostial dimension, whereas with 3-dimensional TEE and virtual reality, we're able to really see that there's an oval shape to the ostium, and that the actual maximal dimension was 30 millimeters. This predicted the correct size of the device, whereas this potentially would have led to an undersized device and led to a parabrascular leak or failed deployment. And so I think when you can't use CT, if you don't have resources available like Dr. Scherer's lab, I think this is an alternative way, not necessarily with virtual reality, but just with 3-dimensional echocardiography, and Dr. Faza had referred to this as well. And with that, I will acknowledge my EP group here at Northwestern who helped out with this case, and I will stop there.
Akil, that was a great case, and a challenging and a little bit of a fake out at multiple times, it looked like. One of the questions as we get the panel involved in the discussion is catheter selection seems to be an interesting topic for the panel, and has come up from the audience. And it seemed that if in your cath film, the shape of the appendage really, in certain angles, was a little bit difficult to achieve the coaxiality. So Poonam, in a case like this, as an interventionalist, how would you go about with device catheter selection?
I think that's a really interesting question. For most cases, it's just this. So we have the single curve, the double curve, and an anterior curve, right? So for most of the cases, if you're able to be coaxial with the transeptal puncture, that's what we want to aim at. The single catheter is pretty good enough. And so I think in this, I see that the catheter was sitting nicely at the ostium, and there was some sizing issue, it seems like, based on Akil's presentation. So I think this, we do a TEE we were doing TEEs pre-op, during and post, while now we have switched to doing pre-op CT scans and ICE-guided procedures now. So I think it's really helpful. The pre-operative screening will be really helpful in picking the catheter shape. But for the most part, the single curve is what we use.
Yeah, great, that's interesting. We tend to use probably 80% anterior curves, and we find that oftentimes helps get into the morphology a little more smoothly. But it's interesting that different institutions have preferences. Marcus, the upsizing of the device compared to CT sizing, do you guys have much experience of that happening in your cases?
Not a lot. It's it usually, like I said, we usually tend to be pretty spot on. Sometimes you get the challenge that I think the next frontier on where we're getting more advanced with this is, I talked a bit about it, the internal trabeculations and how they can be very prominent in some people and interfere with and make things less predictable than you wanted it to. So we're paying a lot more attention to that now in terms of that finding. But usually we're not switching or upsizing.
Yeah, well, what we've noticed a lot here is philosophically, I think people need to start getting into the idea that you're not sizing the appendage itself, but you're trying to size where the device is going to land. And so paying attention to all those little distal trabeculas, paying attention to the osteals, not necessarily the osteal sizing, but the landing zone sizing. So
that's exactly right. Yeah.
Okay, Akil, great case. Do you have any other closing thoughts on your case?
No, I think, it seems as if a lot of labs, a lot of institutions have different ways to image patients. And I think I think every institution has to be comfortable with the way they do it, but also recognize that there are limitations. And I think to have a multimodality imaging capability, especially bringing CT to the frontier, really becomes important as things become more challenging and more devices come on the market.
Well said, well said. Very good. So let's move on to our last case of the evening here. So Dr. Chen is an assistant professor of clinical medicine in the Division of Cardiovascular Medicine at the Hospital of the University of Pennsylvania. She's an interventional echocardiographer with multimodality training and a clinical and research focus on 3D echocardiography, cardiac MRI, and cardiac CT for valvular heart disease. She completed her internal medicine residency at Brown University, cardiology fellowship at the University of Washington, and advanced cardiac imaging fellowship at the University of Pennsylvania. She serves on the Education Committee in the Society of Cardiovascular Computer Tomography and the Image Guide Registry Committee of the American Society of Echocardiography. All right, take it away, Tiffany.
Thanks, James. Thank you for organizing this informative webinar, and thanks everyone for paying attention up until this point. So I'm going to present another challenging case of LAA closure with Watchman. The title I was given was Reasons to Go Vegetarian. Let me advance my slides here. These are my disclosures. Most importantly, I am not a vegetarian. I am a proud omnivore. Okay, all right, so off to the case. The patient is an 84-year-old gentleman with paroxysmal AFib on warfarin. However, he's had several recurrent mechanical falls despite his very high CHATS-VAS score. He has a history of coronary disease, has post-CABG AVR, and also a prior history of TIA, so a typical Watchman candidate. Here you see the baseline TEE, the 2D images here, and I think what you can appreciate is that the imaging is fairly challenging. There is a thick warfarin ridge, which is causing some shadowing into the appendage. And furthermore, if you look at these traditional views of 0, 45, 90, 135, you'll see that the left atrial appendage is fairly foreshortened and difficult to appreciate the morphology of the appendage, as well as what the true depth is or where the landing zone ought to be. Nonetheless, at 135, we measured about 17 millimeters as the max ostium or landing zone width, and length appeared to be about 18, but again, very difficult to appreciate the more distal anatomy. With X-plane imaging, here you see a sort of a close to 45-degree view, and 135 you start to appreciate that there seems to be a bend here next to the pulmonary artery where this looks like a chicken wing morphology. So what did we do next? So this patient did not have a pre-screening CT. We did acquire a nice 3D volume and made some measurements, as well as interrogated the morphology using this eye slice that you see on the right-hand side, and you can see the sort of the bend and the chicken wing morphology there. Some of the advantages of 3D here in this particular case, it allowed us to get better visualization and evaluation of the morphology. I think we're able to get a more accurate landing zone definition, as well as has been mentioned in other talks, more accurate maximal ostial diameter in a setting of an elliptical orifice. So here we measured ostial diameter of 19 with a length of 15 here, just before that chicken wing bend. Proceeding on to the procedure itself, here is the transeptal puncture, which we do under TEE, as well as ICE guidance, which is accounting for that artifact you see. And we have our anterior posterior view, here's our bicaval view on X-plane, and the puncture site was fairly posterior and inferior, as is typical. Here on the next image here, after crossing, we actually have the ICE catheter in the left atrium, as well as the Watchman sheath. And here you can see the trajectory into the left atrial appendage, which seems to be a fairly straight shot. Pigtail was advanced to the distal appendage, and here you see the contrast shot. This is an RAO caudal view, which correlates with our the equivalent of a 135-degree view on TEE. So given the dimensions we had, we were in between a 20 and a 24 millimeter device of flex. As has been mentioned, we really only need 50% of that for depth. So a couple factors into why we chose the 20 millimeter. So intraprocedurally, the patient was administered some volume, and the appendage didn't really seem to increase much in size. That's number one. Number two, I think there was this X factor of what the thick warfarin ridge would do, and whether or not that could potentially contribute to under expansion or over compression of a larger device. So nonetheless, we chose to implant a 20 millimeter flex, and you see it here, as well as how the trabeculations here in the appendage are covered by the shoulders of the device. You can imagine that this is the bend. It's difficult to see on this image, but this is where the wing of the chicken wing is, and the device seems to be sealing off that corner of the bend. Over here on the right-hand side, what you see is the ICE image, which seems to correlate with our 45-degree view on TEE. And in both, you see that the device is well seated. There's no sort of shoulder here, and we actually got a fairly good result. Here's our tug test showing stability. And so the past criteria, the rest of it is looking at size and seal. We see here on 3D that the device is well seated. With 3D color, which has a fairly low frame rate, we didn't see any peri-device leak, but we also interrogated on multiple two-dimensional planes. Now with 3D, we also like to look at the compression, both by 2D and 3D, and our measurements correlated with diameters of 16 to 17, which correlated with 15 to 20% compression. And you can also see the measurement by ICE there. That's all I have for this case. Thanks for your attention. This is my EP colleague, Pasquale Santangeli. And we do have a sort of a multidisciplinary team at Penn involving neurologists as well as primary care physicians to facilitate referrals to our Watchman program.
Great case, Tiffany. And we've got a very relevant question from the audience. Why is the utilization of ICE to guide left atrial appendage closure seem to be so low compared to TEE? When would you recommend ICE be used instead of TEE?
Yeah, so I think TEE is still the standard, because we have the ability to omniplane, we have 3D. I think 3D ICE is still not widely available. I think we're exploring some of the applications of ICE for guidance. I think coupling it with CT in terms of planning and making sure the morphology is, so you know the expectations for morphology, and you might be able to get by with coupling an ICE view where you can get that sort of 45-degree, TE view, coupling that with fluoroscopy to get the orthogonal view of the 135 RAO caudal view, and maybe that's enough for the purposes of deployment. But I think you need to make sure that there is fairly straightforward morphology. So but I be interested in what others think about utilization of ICE and where it's going.
Any
I
thoughts
think it's
from the
a
panel?
great modality to use because we don't need general anesthesia. And so obviously we are, we don't have to put these patients through, a probe and inside their mouth and everything. And so I think if you can get across the learning curve, which I think a lot of operators need to do a certain number of these ICE procedures to be able to become comfortable. But I think overall, like when you're first learning, probably TEE may be a good way to start to be able to understand the anatomy and everything clearly, and then progressing to ICE may be an option.
Yeah, I think those are very good points, Poonam, that, it's sort of comfort with what you're getting on the imaging. So, at the other end of a TE probe is you have an echocardiographer and an imager there. And so if you do the procedure with ICE, you may not justify that extra person. And so becomes, I guess, incumbent upon the operator to understand the imaging.
I think, just to reiterate, this issue of structural heart's all about an ideal roadmap. So if you can really provide that with a CT or a TE in advance, I think when some of the image limitations of ICE are going to give some people, even if you're experienced, not as much confidence as if you knew going in exactly what the anatomy is and you had to, pretty much outline the roadmap. So I think coupling the two together, someone asked, well, why should we bother with a CT? Because we're putting flex in everyone. And like I told you, sometimes you screen out some folks, but in the future, you may want to do ICE. And if you just go to ICE and it's not as easy for you to understand what's going on, then that's an issue. And in addition, if you have other devices for more complex anatomy, like the amulet, you get to know all that in advance. So there's no surprises when you get to the room. And I think that's a lot of what we do. We don't want any surprises. We want to just have the plan outlined, come in the lab, and have it, all step-by-step approach that you think is going to work out for the patient. And so much of this is tailored because of all the variation in anatomies that patients have.
Yeah, that's a great point. Nadine, you do so much TE for these procedures. At our institution, we tend to try to volume load similar to what Tiffany does at her institution, particularly when we get small appendages or maybe some challenging imaging and angles. Do you have any thoughts on what you guys do at your institution and tips of how to optimize imaging?
Yes, we do the same. We give some volume because with volume you can expand that left atrial appendage and you can measure the landing zone more accurately. So we do give volume. And then to touch back on the topic of ICE, because this is important, I think the use of CT has really allowed expanded use of ICE because, as mentioned, the anatomy, you know the actual dimensions. So if you have that anatomical evaluation performed by CT, it's easier. A lot of our EP folks would do CT and then would do ICE for guidance. You don't need anesthesia and all that. The limitation, of course, is that you get different images, but for simple cases where you have your pre-CT for evaluation, a lot of our EP physicians are leaning more towards ICE at this point.
Great. Well,
And
wonderful case. Yeah, go ahead.
I was just going to say, there's also improvements in the ICE catheters that are coming along as well. And so there are, obviously 2D ICE catheters, but now 3D ICE catheters, some of which are being manufactured and significantly improved upon older versions. And so as the ICE catheters have larger fields of view and are able to have better spatial resolution and more ability to do on-cart multiplanar reconstructions, I think they will be an increasingly important tool.
Yeah, another aspect is sort of, as we have more imaging modalities at our disposal, how do we fuse the modalities for real-time procedural guidance? ICE is still in its infancy, but if we could fuse ICE with fluoro or CT, and I think that would be incredibly powerful for left atrial appendage closure.
Yeah, I'd like to ask Dr. Ayman Smer, who has joined us as our social media moderator today, if he has any final comments or anything that he wants to share about Watchman procedure from his program.
Yes, yeah, thanks, Bonami. Thanks, everyone. This was a great session. A few points I want to mention, like everyone said, every patient is different. They have different anatomy. We have different modalities. Some patients that CT would be the best test to do. Some people like ICE would be very helpful to use. So there's no one size fits all. Every patient is different, and use that. I think I'm excited about that AFib Champion trial that you talked about, because right now we offer Watchman or any left atrial occlusion device for patients with high risk of bleeding, and that's in the future. That may be the way to go. That would be head-to-head between left atrial occlusion devices compared to NOACs. We have a few questions that we posted on Twitter from the audience, so I would like to share them with the panel to have answers. So if you have a few seconds. So one of the things, the left atrial appendage occlusion in the most recent ACC AHA guidelines is listed in what level of indication? Level 1A, level 1B, level 2A, or level 2B? Most audience answered as level 2B. So I want to hear the audience, the panelists. Do you agree with that?
Yes, I think Brian's presentation clearly stated that, showed that.
Yep. Another question, which one of the following is the appropriate indication for left atrial appendage occlusion device in patient with recent GI bleed while on warfarin, INR of 2.5 therapeutic? Valvular AFib, non-valvular AFib, or atrial flutter? I want to comment especially on the atrial flutter. What the panelists thinks on that question? And that will be the last one.
Is it non-valvular AFib?
Yes, non-valvular, valvular, and atrial flutter.
Great. Well, thank you so much, Ayman. Thank you so much to all our speakers and the panelists and all the case presenters. This was a wonderful evening. I really appreciate everyone's time and the audience for taking time to join us tonight. And Tina, if you have any concluding thoughts to close us out here, that would be wonderful.
Yeah, thanks, Dr. Lee. I just wanted to thank our presenters and our participants for joining us today, and to let everyone know that today's program is copyright 2021 by the American College of Cardiology with all rights reserved. And this concludes today's program. Thank you. You may disconnect.
Thank you all.
Thank you all.